as a medical advisor at Hetero Healthcare. Our topic of today's discussion is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding on the management of PPH and role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years. It has more than 300 products in its portfolio and has employee size of 21,000 globally. Hetero is among the largest manufacturers of ARVs, API, and FDF in the world. It has 36 state-of-the-art manufacturing facilities and has its presence in more than 126 countries. Hetero also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. During the COVID-19 pandemic era, Hetero was pioneer in antiviral and offered oseltamivir, favipiravir, and remdesivir in its respective dosage forms. Now, I would like to introduce our speaker for today's meeting, that is Dr. Avadhut Kashid sir. Sir is currently practicing as an obstetrician at Dudhal Maternity Hospital in Bhoom, Osmanabad. So, with this, I welcome you, sir, and hand over the session to you. Over to you, sir.
Okay. Okay.
You can just
Hello.
let me know
Good
when
evening, everyone.
you can just let me know, sir, when you want the next slide. I will just switch from my end.
Okay. Good evening, everyone. We are discussing now overview of postpartum hemorrhage and action of carbetocin in that management. Next. Postpartum hemorrhage is normally defined as more than 500 ml blood loss in vaginal delivery and more than 1000 ml blood loss during cesarean section. PPH is a common, can occur even in women who are not at risk. PPH leading to cause maternal mortality, low income countries, and primarily cause near 1/4 of all maternity death globally. Next. PPH is most common cause of maternal mortality, leading to cause maternal mortality according to about 35% of all maternal death. MMR in developing countries was 240 per 1 lakh live birth compared to 16 in developed countries. Maternal mortality ratio, global PPH incidence, 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% of after vaginal delivery and 6% after cesarean section. Incidence in India about PPH is 38% of maternal death are due to PPH. Out of that, 25.7 of global death take place in India. 2/3 of these attribute to PPH. India has unexpectedly high maternal death rate, 450 per 1 lakh live births. Next. Etiology of postpartum hemorrhage is major are tone, thrombin, trauma, and tissue. Tone in uterine atony, inability to uterus contract may lead to continuous bleeding. That can cause torrential bleeding during after delivery of placenta and baby due to atony of uterus. Second may be thrombin, that coagulopathy is failure to clot. Trauma may be during birth birth that canal rupture of uterine in or almost rupture of uterine artery that can cause hematoma or torrential bleeding. Maybe retention of placenta, maybe placental retention bit that can cause much bleeding that also leads to PPH. Next. Clinical finding of PPH, abdominal tenderness, circulatory collapse, increased abdominal girth, loss of uterine contraction, maternal tachycardia, and vaginal bleeding. Maybe there is a abdominal tenderness due to over distension of uterus due to bleeding or collection of clot in that uterine cavity. maybe abdominal girth is a major component that can be monitored after cesarean section या vaginal delivery. Loss of uterine contraction or tone that can be we can clinically correlate, and maternal tachycardia due to torrential blood loss. Next. For development of carbetocin in new heat stable formulation. Carbetocin is available in room temperature stable formulation, convenient vial presentation. Oxytocin and carbetocin. Oxytocin can be used as a carbetocin previously. This was the drug of choice, but now almost all gynecologists can use carbetocin as a drug of choice for PPH management because of some, maybe first factor is a heat stable formulation of carbetocin that can be very advantage for small maternity clinics where cold chain is not maintained properly. At that time, the efficacy of oxytocin, yeah, carboprost can be hampered, but heat stable carbetocin can be used very properly, and mode of action also so fast. So oxytocin and ergot alkaloid should be kept in refrigerator, avoid degeneration. Stable or heat stable formulation of oxytocin is currently not available. Previous formulation carbetocin should be stored between 2 to 8. Resources poor countries do not always have cold chain transport or storage capability. Over that, the carbetocin is stable at room temperature. Shelf life is of 24 months at 30 degree and 75% humidity. Avoid need for cold chain and storage and provided in vial. Next. Use of uterotonic agent. Time of administration at the crowning of baby head, at the delivery of anterior shoulder, at the end of second stage of labor, and following the delivery of placenta. Prophylactic use, prevention of PPH, active management of third stage of labor, and therapeutic use as management of PPH. Molecules used is oxytocin, carbetocin, ergometrin, and misoprostol. Next. Next. Carbetocin clinical efficacy and safety of carbetocin versus oxytocin, or carbetocin non-inferior than oxytocin who campaign trial. Carbetocin decreases need of uterotonic agent versus oxytocin. Single dose of carbetocin versus continuous infusion of oxytocin. Comparison of carbetocin and oxytocin with respect to reduction in blood loss and need other interventions. Efficacy and safety of carbetocin were cyanometrin. Effectivity and safety of carbetocin versus misoprostol plus oxytocin. Next. Oxytocin and carbetocin, there are synthetic cyclic peptide from the naturally occurring posterior pituitary hormone, binds to oxytocin receptor uterine myometrium and stimulate contraction of this uterine smooth muscle by increasing sodium permeability of uterine fibroid. But this is a short acting oxytocin, but carbetocin is a long acting synthetic analog of oxytocin with agonist property. Binds same as a oxytocin receptors in uterine smooth muscle and increase contraction tone of the uterus. Pharmacokinetics, oxytocin can be given IV or IM, same as a carbetocin, but dose Dose is higher than carbetocin. Oxytocin can be given 20 to 40 units, and carbetocin only 1 ml injection diluted in 10 ml over 1 minute slow bolus dose. Mainly half life of oxytocin is less, 1 to 6 minutes only, but half life of carbetocin is better than 40 minutes. Mainly we are discussed just now that heat stable, no need of maintaining a cold chain. And clinical indication, oxytocin has more due to augmentation of labor, induction of labor, and treatment of PPH, both are same. Next. Carbetocin not inferior to oxytocin, which campaign trial has given. Campaign Carbetocin hemorrhage prevention, the largest clinical trial in prevent of PPH. Trial conducted by WHO Department of Reproductive Health and Research. Study design non-inferiority double-blind randomized trial is conducted. Objective is that compared effectively and safetiness of individual heat stable carbetocin to oxytocin for prevention of PPH and after vaginal birth. Patient enrolled around 30,000 women across 10 countries, including India. Primary outcome is proportion of women with blood loss at least 500 ml or use of additional uterotonic agent, and the proportion of women with blood loss at least 1000 ml. Next slide. Both drugs are compared. At the time, more than 400 ml use of additional uterotonic. Efficacy of carbetocin around 14.5% and oxytocin are at 14.4%. Normally equally just 1.1% ratio, but that make big difference. And in blood loss of more than 1000 ml, it is around 1.51% and oxytocin 1.4%. Add concern to safety, at least one anticipated 4.9% safety with carbetocin as compared to oxytocin 4.7% only. The frequency of blood loss at least 500 ml or use of additional uterotonic agent with carbetocin was proven to non-inferior versus oxytocin. The use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between two groups. Conclusion is that carbetocin was not inferior to oxytocin for prevention of blood loss at least 500 ml or use of additional uterotonic. Next. Cochrane review suggests that carbetocin is a preventing postpartum hemorrhage. In this Cochrane review, data from 11 studies involving 2,635 women were included. The author conducted that for women who undergo cesarean section, carbetocin resulted in stat statistically significant reduction in need of therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to cyanometrine in prevention of PPH for women who have vaginal deliveries, and also associated with cesarean section, significantly fewer with a significantly fewer adverse effect. Next. Guideline recommended. WHO in 2018, only one of the following is recommended: oxytocin, carbetocin, misoprostol, argometrin, or oxytocin plus argometrin fixed dose combination. SOGC Canada recommended carbetocin 100 microgram IV bolus. Ranzoc New Zealand active management of stage of labor prophylactic uterotonics. Figo एक मिनिट. FICO advice carbetocin is one of the recommended for prevention of PPH. Germany, same. FCOG, France also recommended carbetocin as a proven drug for prevention of PPH. Next. My experience of carbetocin, I am using since almost 1.5 year, 1 to 1.5 year. I am using to every patient after cesarean delivery or vaginal birth. The patient PPH incidence was almost nil. There may almost 1.5 year. Before that, with the use of pitocin and methergine, misoprostol, yeah, carbopros, sometime it can cause heavy bleeding. I need to do repeat doses of oxytocin, methergine, or sometimes repeat misoprostol. But since I am using the carbetocin, I didn't get any single case to repeat that dose uh, repeatedly. Yeah, no much bleeding is there. Next.
Any Hello, sir. Sir, any more
Ah,
cases or experience or your comments if you would like to add?
oh, I am using almost every case for as a prevention of PPH, not for management. But since I am using that carbetocin, I get much relief or no headache or tension of PPH or that are mostly that useful in placenta previa cases, yeah, twins cases. It works lot much better than oxytocin and methergine.
Okay, okay. Okay, thank you, sir.
Or okay. A major though adverse effects are there with oxytocin, misoprostol, yeah, carboprost. Uh, Oxytocin is a short acting and prolonged use, yeah, overdose use can water retention. Misoprostol can pyrexia or carboprost can vomiting diarrhea much better. But major adverse effect of carboprost is that cannot be used in asthma or major renal, hepatic, cardiac diseases patient. So there is no as such contraindication to carbetocin now.
Okay, okay, yes. Means we can say that safety wise, it has many of the advantages.
Yeah. Safety wise, efficacy wise, carbetocin is stable. So our small maternity homes that can much advantage of that. Due to there is no proper maintenance of cold chain. So efficacy of oxytocin या carboprost so तो मिनिमल तो hampered हो जाता है. तो बेटर वे कार्बेटोसिन ही स्टेबल है तो बाकी कुछ इशू नहीं आता.
Okay, thank you. Thank you so much, sir, for sharing your valuable insights and your experience as well. Now we move forward to the next part of our session, that is panel discussion, where we would be having some frequently asked questions and real world scenarios. So,
Okay.
moving to the panel discussion, sir, the first question is what is the incidence of, means why is the incidence of PPH is more in India? What are the factors or reasons for it?
Major factors are facilities available or awareness of patients about deliveries. Most of in rural healthcare, there are more deliveries are carried out at sub centers where drugs are not available properly or proper dosage was not given there. Most of times, traumatic PPH are more uh, uh, due to deliveries are not properly done. Most of it tear, yeah. That's why there is more mortality due to PPH in India.
Okay, okay. Thank you, sir. Moving to the next question. So, sir, what are the patient profiles where doctor can anticipate PPH? Means particular patient profiles in which there is high chance of PPH, we can say.
Majorly, first is a placenta previa. In that, due to lower placenta situated in lower segment, due to contractility issue, we can expect that PPH in placenta previa cases first. Then twins pregnancy or the patient on IVF or recurrent pregnancy loss who can take low molecular weight heparin since almost 8 to 9 months, they are more prone to for PPH. Or
Okay, okay.
prolonged labor is the most common cause due to patient not coming hospital in proper time. They wait for normal delivery and then may lead to PPH mostly.
Okay, okay. Thank you, sir. So, moving to the next question. So, sir, you characterize certain factors in which there is high risk of PPH. So, considering anemia, so prevalence of anemia is also high in India. So,
Yes, yes,
is
yes.
anemia considered a serious risk
Yeah,
factor for?
yeah. Yeah. Majorly due to anemic patient, oxytocin receptors are were not working well. Yeah, not accepting oxytocin drug properly. Yeah. So maybe cause uterine atony in anemic patient also. But incidence was low there, but major cause is twins placenta previa on lomo taking patient taking lomos or maybe prolonged labor is a major cause of PPH.
Okay, okay. Got it, sir. Yes. So, moving to the next question. So, which drugs, sir, do you routinely use for prophylaxis of PPH?
I am using each and every patient with carbetocin for prophylaxis only. So this was wonderful drug for me also.
Okay, okay. Means we can means the carbetocin is your drug of choice. We can say in
Yeah, I
PPH
am using
prophylaxis.
Carbac only since 1 year, 1.5 year.
Okay, okay, okay. Yes. So moving to the next question, sir. Do you use carbetocin for prophylaxis of PPH in all the patients or in high risk patients? So and
I am
why?
using for my safety, I am using for all patients,
Okay, okay. Irrespective of the risk, even if the patient has
irrespective
low
of the
risk.
risk. Yeah.
Okay, okay. Yes. Moving to the next question, sir. So, considering the route of administration as IV route is the preferred one, are there any scenarios or patient profiles in which IM route would be preferable and has an advantage?
Advantage is only duration of action for IM. If we give IM for this is 2 hours, and but plasma half life period is also 15 minutes. But we give IV, it fast acting and action is short. But we preferably use IV route because slow drug quantity is less. 1 ml is we have to dilute in 10 ml. So anesthetic will be given it over 10 minutes slowly, IV bolus only.
Okay, okay. Means IV route is in majority of the cases
Yeah,
is the preferred route.
maybe- preferably IV route only.
Yes. Moving to the next question, sir. So, how frequently do you see PPH even after carbetocin?
Not much. I didn't see any case last 1.5 year.
Okay, okay.
In my setup only. Yeah.
We can say that it in your practice it has complete.
Almost negligible.
Okay, okay, yes, okay. Moving to the next question, sir. So even if PPH occurs in spite of using carbetocin for prophylaxis, do you feel that in such cases there could be reduction in the intensity of PPH? Means if carbetocin is used, and even though, but you have already spoken that in your practice, if carbetocin is used, there is no prevalence of PPH.
Yeah.
So, but your opinion on that, sir, if the PPH occurs, then would the intensity be less in that case?
Yeah, definitely. Definitely intensity or bleeding loss will be probably less.
Okay, yes. Thank you, sir. So, sir, what are the advantages of using carbetocin over other uterotonics? Means you have already spoken on it. Any additional comments? And considering its differentiation, it's in its use in either metro cities or in peripheral cities. So, is there any differentiation as such considering its usage?
No. There is all gynecologists are aware about that carbetocin, and mostly carbetocin is heat stable, so everyone can use in cities or peripheries, metro cities. No limitation for that.
Okay, means as cold storage chain is not
Best,
required in
yeah,
zones.
yeah, yeah. Best advantage of carbetocin is that only. Because our small clinical maternity homes are not maintaining proper cold chain, so efficacy of carbetocin, yeah, carboprost definitely hampered, but heat stable carbetocin, no much effect on that na?
Okay, yes. Sure, sir. So moving to the next question. So you have already spoken on this, sir, that the safety of carbetocin. Any additional points regarding its tolerability that you would like to add?
No, nothing.
Okay, yes. So, sir, what is the benefit of using carbetocin as a first-line drug to prevent PPH in every patient and in every delivery? So, you have commented that it prevents PPH in almost all of the cases.
All of the cases it is very useful than oxytocin.
Okay. So, moving to the last question, sir. If you have to summarize and conclude your entire experience of carbetocin, be its safety and efficacy, its usage, and basically your opinion and comments on it. So, what can you tell to our delegates?
Take home message is to use carbetocin, heat stable carbetocin, each and every delivery as a vaginal or cesarean section for our safety or patient safety.
Okay, yes. So, thank you so much, sir. This brings us to end of our session. So, thank you so much for sharing your valuable insights through the session and your experience of using carbetocin in it as well. So, you have summarized its efficacy and safety and your cases as well. So, once again, thank you so much for it. I would also like to thank all the delegates who have joined into the meeting for their engagement and participation. So, this marks the end of our meeting. And
Okay.
yes, we can
Thank you, sir.
close the
Thank you.
meeting. Thank you so much, sir. Yes.
Okay. Thank you, sir.